Hello, ma'am. We kindly welcome you on our page, Follow My Psychology, and thank you so much for coming. So,
Thank you, Anushi. My pleasure.
so for my audience, Syeda Ruksheda is a psychotherapist as well as psychiatrist who has the experience of more than 20 years today, and she has a practice in Lokhandwala, Andheri. She is a celebrated speaker on mental health and two TED Talks to her credit. That was the that was the best thing I heard about you. You have been participating in two TED Talks. So I want my audience to know that you have been giving two TED Talks. So, ma'am,
Thank you.
if we go ahead for today, I wanted to ask that after this COVID, like in this 2 years of COVID, ये जो anxiety, depression, and other disorders related to anxiety have increased so much that I have been hearing a lot of cases about OCD. I've heard that even 13 years, 12 years, 20 years, no matter the ages, but OCD is becoming very frequent in adults as well as in children. So, can you make us aware about what is exactly OCD?
OCD, obsessive compulsive disorder. It's a serious psychiatric disorder. It's whether you call it psychiatric disorder, mental illness. I prefer the term psychiatric disorder because that's the right way of putting it. So obsessive compulsive disorder is a serious condition. It can be a chronic condition. It's a medical disorder. So, it's not just about, oh, I'm thinking in a certain way or something is happening to me in a certain way. It's a medical disorder. And it's a serious illness because it can also be very chronic, like I said. It's hallmarked with, obsessive thoughts or images, which are definitely distressing, right? Because the ego send dystonic thoughts and images maybe. And because they're stuck in my head, they even if I don't want to think about it or I don't want these thoughts and images in my mind, they're there. And sometimes, usually, like I said, because there's so much of distress, so there's also sometimes a compulsive behavior or action that follows that, because I am so fed up of that thought that I need to do something maybe to get rid of that thought, or do something maybe to get rid of the distress. So obsessive compulsive disorder, like I said, it's a psychiatric disorder, it's a chronic disorder, it can be a very chronic disorder, and it's a medical condition that requires more awareness because it is very, very common. It's more common than one would even imagine. And of course, because we don't know a lot about it, we don't talk about it. So a lot of us go undiagnosed, we continue to remain in distress, and that impacts our daily activities and relationships. But because we don't know that help should be taken for it and help can be taken for it. So I'm very glad that you're doing a topic on obsessive compulsive disorder, because also now, in pop culture, it's become so kind of prevalent. Oh, this is just my OCD or something like that, right? So on one hand, I'm so happy that the word is, used more often and clearly known by more people more often. Having said that, the way we bandy it about might also be doing a disservice to it. So yeah, again, circling back to obsessive compulsive disorder being a psychiatric disorder requiring treatment is what OCD is about.
Right, exactly the way you said that OCD is being used very commonly. And though it is so serious, it has been seen so commonly in children and adults. Like I go to hospital and I was shocked that day. In a line, I saw 5 to 6 patients coming for OCD and they were younger than me also. So it is a bit serious as well as common thing. And you said that it has been used very, very lightly. I have heard celebrities using, many people using, my friends are using, that मेरे को OCD हो गया है. I feel this seeing some uncleanliness. I feel OCD and about it. So people are using it lightly, though it is being an awareness, but as well with it, it is like not fair with the people who are really suffering from OCD.
So like I said, use of this so casually can also, in fact, take you away from the seriousness of the situation. You see, so that's one of the problems with that. I know we got a little off track because I mentioned it there earlier, but when you were saying that, okay, there are so many young people that you're seeing. So what most of us, the people who are not in the medical field or paramedical field of psychology, might not realize that psychiatric illnesses are they start young. 50% of all psychiatric cases are before the age of 14 years of age, and 75% before the age of 25. So if you're going to look at it, of course, OCD being a major psychiatric illness is also going to be more prevalent in this age, isn't it? As young as 8, 9, 10 years of age, children and teenagers and young adults can and do get diagnosed with OCD. This is the time for it, because just like other psychiatric illnesses, even if it's depression and anxiety, I'm sure you would have heard it so often that, oh, this person is so young, or this is a child, aise kaise ho sakta hai. That's because, again, we don't understand that it's not a reaction to a particular social life event or trauma. Just like every other psychiatric illness or every other physical illness, OCD also has underpinnings of genetic vulnerability. If I don't have a genetic vulnerability towards OCD, I will not get OCD. But if I have a genetic vulnerability towards OCD, I might the illness can be triggered by a life event like pandemic, like a worry, health worry. Even in a lot of women, when they start menstruating first, or need to go out and start using public toilets often. So those triggers can definitely be a risk factor in that sense, but they're not the cause. The cause is the genetic vulnerability that I may have towards a certain illness. And yes, like you said, we are seeing more young people, and I'm so happy about it that parents are no longer kind of hesitating. Of course, this is still more prevalent in the urban and more developed areas of our country, but we are getting there. We're getting there.
Right. So I was going to come about the second question, which you mentioned over the genetic vulnerability. I was going to ask you, according to this disorder, what can be a root cause for this disorder to be in an individual?
So when like we said that, okay, if I have a genetic vulnerability, there may or may not be an external trigger or an internal trigger. Like I could have another disorder like hypothyroid or diabetes or something else, or an infection for that matter, or an inflammatory process for that matter. That can be an internal trigger for the OCD to start, or an external trigger, like I said, like a life event or something that I'm be getting stressed about, and that stress can then trigger my illness. So what actually happens is that there are areas of our brain that are more prone to getting impacted. How the brain functions, or in fact how the entire body functions, is by nerves conducting information through electricity, through chemistry, right? Neurotransmitters and all of that. So there are particular areas of the brain and particular kind of like pathways in the brain that are dysfunctional. Let's put it that way, right? Particularly like for OCD, we can say that your orbitofrontal activity is dysfunctional. So that particular area probably, right? Along, of course, not just that, but I'm just giving a very simplistic kind of like an answer. So when there's a dysfunction in the brain, of course, you're going to have symptoms. Just like if I have dysfunction in the brain, I can get an epileptic seizure, right? If I have a dysfunction in my brain, I can get a migraine. If I have a dysfunction in my brain, I'm going to get a paralytic attack. The same way, if there's a dysfunction in my brain, I'm going to get certain symptoms. And if this particular dysfunction area is dysfunctioning, I'm going to get symptoms of OCD. So that's the causative factor. That's what's actually happening. And we know this because we've done so many MRIs and fMRIs and brain studies, both in animals as well as human beings. We also know this because what chemicals are involved, particularly serotonin and dopamine and norepinephrine. We know that these are the major neurotransmitters that are at play, because we also know that, okay, when we give medications for this, that are targeting this kind of function of the chemistry as well as the brain part, then there is relief in the symptoms of OCD. So we have a lot of scientific evidence to suggest that, okay, we know we have a good idea in terms of what's happening in your brain, and that which is causing you symptoms of OCD. So when we give you that treatment, the symptoms are going to reduce because the dysfunctionality is going to get better.
Right. So earlier we also mentioned this thing that there are a lot of people suffering from OCD, but they themselves are not aware about that they are going through OCD or they're having something wrong in that. So can you tell us some symptoms of OCD that people can relate to or come to know that there's something wrong with them and they can come out for their treatments?
Right. So like I said that, first there is kind of like an obsessive thought. We call it an intrusive thought for the simple reason we don't really want that thought and it's just come and it's like, it's sat there very, very strongly.
Right.
So which is not to compare it with, when, like I always tell people that, you have a song that gets stuck in your head, right? For maybe a couple of days, you're just humming, even when you don't want to hum it, you're just kind of like humming that song again, or you're thinking about that song again. So this is not exactly that, but this could be like, when you think about it, it's like an 1,000 degrees exaggerated version of that
Yeah.
song gets stuck in your head. So a thought could get stuck in my head. More often than not, that thought is not very nice. That thought
Yeah.
is
This
not
was
pleasant. The thought is not giving me peace or happiness. Like the song, if it's a favorite song, I might not even mind humming it for 2 straight days. But if a thought is getting stuck and it's it starts interfering, that I can't focus on something else. So the thought could be of contamination, like, oh, I just touched this, my hand's dirty and I should clean it. So that could be a thought that that's just stuck in my head. So even if I'm trying to, like, I'm talking to you, but my brain is like, oh, my hand is dirty, my hand is dirty, my hand is dirty. Or a lot of the other very, very common thing is checking and rechecking. I've shut the door, but I do need to make sure that the door's shut. I know I've shut it, but I still think that, what if I haven't shut the door? Whether that's a fridge door, or a gas stove, or a car door, or a house door, right? Oh, I've read like this particular contract, but I need to read it again so that I make sure that this is something that I haven't made a mistake. So contamination and checking and rechecking, these are major thoughts that do get stuck. A lot of the times, they are images that flash in our brains. So it might not be a thought that is stuck, but an image that's stuck. A lot of the times it's blasphemous thoughts. People they're so distressed because they have either sexual images where, as far as God is concerned, or bad words as far as God is concerned. So that makes them feel awfully guilty. That, why can I not stop thinking about it? Does this make me a bad person? Is this going to make me go to hell? Does this mean I'm not whatever religion that they're following? Does this mean I'm not like a Hindu or a Muslim or a Christian? Does this mean my faith is gone and I'm going to go to hellfire? So these are some of the common kind of really thoughts and images that might get stuck in our head. So when we have these thoughts or images in our brain, that brings with it a lot of restlessness or anxiety or bad feeling or guilt or shame, right? So then there is I need to do something to relieve that anxiety, to remove that thought from my head. Because a lot of the times it could also be like something that, oh, if I now this the thought has popped in my head. Now if I don't touch this particular object, or if I don't say this particular prayer these many times, somebody in my family or somebody in my friends is going to die. And then it would be, then of course, so even if I know, while I know that that's illogical, but I can't not repeat that action, because I can't live with the guilt if suppose something does happen. And at the same time, so even when I've convinced, I know that that's not going to happen, they're not going to die, and it wouldn't be my fault, but I still don't like the distress that I'm feeling, the anxiety that I'm feeling, the restlessness that I'm feeling, and I want it to stop. Because I want it to stop, I'm going to do that action, right? I'm going to, a lot of the time, especially with young people, they will keep going for reassurance. They will keep asking their parent, this thought's coming in my head, but that's not going to happen, right? And then the mother or the father or whoever needs to say that, no, that's not going to happen. So then they're okay for some time. Then again, after a few hours, they might come back and want that reassurance again. So that wanting, needing that reassurance also is a compulsive behavior. And And a lot of the times, unfortunately, like I said, because it's, coupled with anxiety, there could be panic attacks, and it's so distressing that there is also coupled with depression. So then we have two illnesses, OCD, and then either depression or anxiety, even though anxiety is part of OCD in a way, but there could be panic attacks as well. And then majority of your day kind of is like, either fearful that, oh my God, that thought's going to come to me, or the thought is there and you're not going to be able to go about your daily activities. It's going to impact your performance at work, whether that's at school or college or
Right.
at your job. It's going to impact your interpersonal relationships. For simple example, suppose if I have a OCD of contamination and I need to wash and wash and wash. Suppose if I'm living in a metro city where maybe 5, 6 of us share one bathroom, and I'm spending close to hours. If I go to the washroom, to toilet, I might spend 45 minutes to an hour. If I'm taking a shower, like a bath, on a daily basis, I might spend 2 to 3 hours. So if I'm occupying that a single washroom for so many hours, it's going to naturally then create a lot of issues in the house, and there are going to be fights on a daily basis. Not to mention that I would drain the entire water tank, isn't it? So that's also something. So that leads to a lot of not only just personal distress, but interpersonal issues as well. So these are simple, these are very common kind of like things that we do see. And then people around them, because, with OCD, there are no hallucinations, there are no, like a simple OCD, not a complicated OCD. So it's not as if somebody can recognize that there's something going on. Because it's such a logical thing, people think that, but she knows it's not dirty. Why is she cleaning it? Why can't she just stop? So people don't get that, because a person themselves also doesn't get it. I know it's not dirty. Why can't I stop it?
Right.
So people go a lot of years, because there is sometimes very gradual increase in the symptoms. So a lot of the times people might themselves or other family members might not recognize. Of course, there is waxing and waning of symptoms. Sometimes if I'm under stress, my symptoms are definitely going to increase. Sometimes even if I'm happy, it's an exciting moment in my life, I'm still going to have increase in my symptoms. And so those waxing and waning of the severity of the symptoms is definitely there as well. So when there is more the severity of the symptoms, that's when generally people come to us for help. And when you trace it back, people will tell you that, yeah, I always had like these particular things that I needed to do in a particular manner, but this was never a problem. So why is it a problem now? So, so these, like I said, the uptick in symptoms can happen for various reasons or for no reasons at all. And the pandemic didn't help with so much of, especially last year in 2020, where there was less information and everybody's so worried about, the infection. So a lot of health related obsessive thoughts, that was definitely a rise in that.
Right. Even while saying this, you mentioned two things, that with OCD, that person can even suffer from depression, anxiety. So, is there any other comorbidity? Because you even mentioned the word hallucinations while speaking about it. So, can you tell us if any other comorbidity there are? And for my audience, comorbidity is something where two disorders or more than two disorders exist in a person, individual at the same time. Yes.
So a lot of the times, we do see OCD in people with a lot of past trauma as well, whether that trauma is verbal, physical, or sexual. So, a simple thing like a girl had her periods and she stained her clothes, everybody laughed at her. And since then, the OCD of cleaning and uncleaning started, or OCD of the color red started. So even that traumatic experience can also be there. So a lot of the times we do see this kind of like a PTSD situation as well. Like we already mentioned, there's depression as part of the syndrome of OCD, and also depression because the brain parts and the neurotransmitters that are involved can also, are similar, the similar dysfunction and activity in the brain for depression and anxiety as well. So when you do have OCD plus another illness, of course, it complicates the case, and it complicates the person's life a little bit more. So we very commonly, like I said, we do see anxiety with panic attack, we do see depression, we do see PTSD, we do see a lot of substance abuse as well, because a lot of the times people are like, okay, if I just, at the end of the day, I'm just gonna take something and just knock myself out. So that we can see that as well. A lot of the times there is a lot of self-harm because a lot of dissociation. A lot of the times there's so much of suicidal ideas and suicidality as well, because the sheer exhaustion from OCD. Because more than anything else, OCD, you'll see like a lot of people, if you just ask them, how are you feeling? And if you ask them like with a little bit more empathy and listen empathetically, they'll tell you how exhausting it is because their mind is forever working. They have, even when they're focusing on something else, a lot of their energy is going in terms of keeping those other thoughts, obsessive thoughts, and trying not to do the compulsive action. So it takes a lot of mental energy. So a lot of exhaustion is also something that's very common. Of course, children with ASD, autism spectrum disorder, also we see a lot of kind of cases with that. So when we also, so if you want to look at it, in terms of OCD in itself, it could be a primary or a secondary illness which got triggered by something else, or it triggered something else.
Right. So initially I was going to mention this when you were talking about compulsion. Right now, there are a lot of compulsions which are mentioned in the DSM books and the ICD. But right now, the compulsion of Googling a thing again and again has arisen newly. Like you Google out. I have seen children who are coming out of OCD, Googling the same thing, and they are reaching to extent that I have nothing. Okay, I have OCD. Then the same idea arises back. They start Googling again. So how can this Googling can also be a compulsion?
So it's just like I was just describing earlier, a child will go to the mother that, oh, I kept this thought, that's not going to happen, or this is not like that. So it's about reassurance. It's about looking for reassurance, right? So when you're Googling whatever thought that you're getting, whether the thought is about a health anxiety, or the thought is about a blasphemous thought, that does this make you a sinner? Does this make you, is this pardonable sin? If this thought came to you, are you going to hell? So people will Google all of that and get those answers. So wanting those answers and needing those answers, not just wanting, needing that reassurance is a compulsive behavior as well. Whether that reassurance now, because we are so used to not only just asking people but Googling things by ourselves, so it's just that the symptom and the action is the same. It's just the method has changed a little bit. So instead of me only asking for reassurance from other people, I'm also going to ask for reassurance and look for reassurance in Google.
Okay. So by this, we can say that OCD is totally a neurotic disorder.
So we don't, scientifically, we don't really distinguish between neurotic and psychotic, because we understand that they are not separate in that sense, isn't it? It's the functionality of the brain requires multiple things to go hand in hand. So in the similar way, the dysfunctionality also requires multiple things to go wrong. So it's neither a purely neurotic or a purely psychotic illness, because that's just like a very old and a very simplistic way of looking at a disorder. And OCD is a very, very complex disorder with a lot of overlaying symptoms and psychopathology with other symptoms and other disorders of in psychiatry. So yes, that's why also diagnosis can be, that diagnosis is very essential to reach. That's why you need to go to a psychiatrist or at least a clinical psychologist who's going to diagnose you properly, and not get either self-diagnosed or get diagnosed by maybe a qualified mental health professional, but not somebody who's qualified to actually diagnose you. So, yes, clinical diagnosis is important based on history and symptomatology. There are also some scales that we can use just to kind of like, when we're treating that, okay, on point 0, when you first came in, this was your level of illness. And then maybe after 6 weeks, we do the test again just to see how the level of illness is. But again, those are helpful tools for diagnosis and treatment, but I don't necessarily need to do that. And as far as diagnosis is concerned, I may or may not want a scan, an MRI scan. I may or may not want other kind of neuropsychiatric testings. Again, it entirely depends on person to person. Of course, if possible, at all possible, we will always do routine examinations, blood work, including looking for anemias and vitamin deficiencies or other metabolic disorders like thyroid or diabetes and things like that. If somebody already has another pre-existing condition, even like PCOD, of course, then we are going to look at that more closely, because that's going to also increase the symptoms of any psychiatric illness, including OCD. So if I don't correct that other pathology, this psychopathology is also not going to get corrected very easily.
After talking about the causes, the symptoms, now we finally come on the treatment of OCD. So tell us about what is the exact and what is the perfect treatment. Like we, as a psychologist or as a aspiring psychologist, I know that any kind of disorder needs psychotherapy as well as medications equally. So does OCD also goes like this?
Oh, most definitely so. More in OCD than in other psychiatric illnesses, honestly speaking. Like even if you have major depression, suppose you don't take therapy and you only take medications, you might be okay. Even if you don't take medications, but if it's a mild case and you're only doing therapy, that would still be okay. But with OCD, whether it's mild, moderate, or severe, combination of medications plus therapy is a must. I know that I have advanced directive that if I have OCD, I'm going to go through, or both these options. Of course, because like I said, there's waxing and waning of symptoms. We may choose to only do therapy for certain time and not maybe give medications. But frankly, the outcomes are not as great if you're only doing one modality. The outcomes are definitely better, not only in terms of symptom relief, but also functionality getting back the functionality improvement, and also relapse rate. So combination of medications and therapy is very important. And please understand that I'm saying therapy and not just counseling, because therapy for OCD particularly requires a very structured kind of an approach, and a very structured kind and very dedicated kind of a pursuit of changing your mental patterns, because there's so much, it's so easy to kind of go back into those same kind of thinking and the same kind of compulsive, when the compulsive thoughts and intrusive thoughts are there, it's so easy to go back to slip back into those compulsive actions with the obsessive thoughts. Like structured evidence-based therapies like a cognitive behavior therapy, or even rational emotive therapy is very, very important, a part and parcel of treatment. And medications are very important, because a lot of the times the symptoms are so severe that you, without starting first on medications, reducing the symptoms, reducing the distress, reducing the anxiety, there is no ability to focus on therapy. So a lot of the times initially there's only medications, and then we introduce therapy. In CBT, cognitive behavior therapy, what is also most important is exposure response prevention. So ERP, that's something that's very synonymous with OCD. So if you do have even a mild form of OCD, please ask your therapist if they're doing therapy or counseling, and what kind of therapy, and are they qualified for it or no, because not for any other reason, because you do need to learn these skills so that your outcome is better and you have better control over it. At the end of all of this, I am going to tell people that please remember that just like other illnesses like diabetes and hypertension and thyroid and PCOD, psychiatric illnesses, we say that they are treatable. They are not curative. It's not like we are curing them, but we can definitely treat them. So just like with diabetes, you're not really going to ask your doctor that is my diabetes is ever going to get better. You know that you're going to be on medications for practically lifelong, right? So same with the psychiatric illnesses, you are going to have, like I said, you're going to get treated and not cured. Of course, unlike diabetes and blood pressure, there is always a possibility that I'm going to get off medications and I'm going to definitely get better. So that's good news. So we are kind of like diabetes, hypertension, but we are better than diabetes and hypertension.
Right. So, as you said that we understood that even if you have OCD today, if you get therapy, you get medications after a time span, after getting better on your medications and therapy, you can have a normal life. You can lead a normal life, proper functionality, like your pre-morbid personality.
So okay, I'm gonna do a lateral push here. You're always normal. You're normal
Okay.
with certain symptoms, right? If a person with diabetes and blood pressure is considered normal, a person with symptoms of depression, anxiety, or OCD is also normal. It's just that, yes, they are not normal in terms of a health profile, but they're normal in terms of psychologically how we tend to think about normal and abnormal. So when I have diabetes and I don't say that I'm abnormal, if I have OCD, I'm not going to say I'm abnormal in that sense. I definitely have a medical condition that I need treatment for. So yes, but like you said, that with treatment, especially a combination of medications and therapy, there is a better chance of me not only having a symptom reduction, but also return to full functionality. And full functionality means I go about my everyday life without having these intrusive thoughts or anxiety that comes with these thoughts or guilt that comes with those thoughts and those compulsive behaviors. And I don't tend to sit and spend hours in a day thinking about my OCD or being involved in my OCD process and structure, the cycle. So yes, definitely we do go back to having like quote unquote normal lives.
Right. So, yeah, we got a lot of information about OCD today, but the last thing I want to ask is there's a lot of shame, guilt, and everything to come for people to come out and speak about their OCD, about their thoughts, because as you said, they're intrusive. Sometimes they are very shameful to talk about. As we said, there are sexual images in the thoughts and everything. There are thoughts about suicide, so that people think that people will worry about me and everything. So two things I wanted to ask is that what would you say to like the patient, maybe the younger generation, the people who are getting aware, like maybe 20s or 13s, to tell about their parents to accept, because the parents are not able to accept when the children come and tell them. The parents say that it was a phase, it has come with us also, it will go away. But people don't realize that it's not a phase, it's a condition which is not going to go away without a proper treatment.
See, the thing is, the reason that people find it so difficult and there's so much of kind of like, avoidance of acceptance, and I'm going to say avoidance of acceptance, because people definitely want to avoid accepting that this is a reality, is again, because of a lack of genuine understanding, because people still tend to think of psychiatric illnesses as, a weakness or as something that's we've brought upon us or as a lifestyle disorder for that matter. And these are not. So when people get the science of it, okay, this is what happens, there's less stigma. Okay, we just went about, talking about the vitofrontal cortex, and we're talking about serotonin and dopamine and norepinephrine and fMRI. So when we're talking about like a basic evidence-based science, people understand that better, that, oh, it's nobody's fault.
Right.
And oh, this happened. So definitely bringing its evidence-based, science-based kind of proof to your conversations and discussions is going to reduce the resistance to talking about it as well, because then people are not going to think of it, okay, what's wrong with you, why do you have OCD, as if like you did something to get OCD. So definitely when people are going to, like I said, involve this part in their conversation about illnesses, it's going to be easy. And the problem with having acceptabilities also is because all of us have at some point or the other faced some of these symptoms at a milder level, isn't it? Like all of us have felt sad because things have happened, or we've been sad. So people think that, oh, I felt sad and I was fine. So but what people don't realize is there's a difference between sadness and depression as an illness. The same way, yeah, I have headaches, but there's a difference between a headache and a migraine, which could be crippling. Yeah, I've had cough, but there's a difference between having a cough and COVID or tuberculosis for that
Classes.
matter. So that if when people start recognizing that okay, sadness does not mean depression, or sadness is different from depression, or thought stuck in my head is different from OCD, that's when they're going to recognize that, okay, they're not going to just take it that oh yeah, so what if you've been coughing for 1 month, We don't say that, right? So the same way, if we say that, oh, so what if we don't start saying, so what if there's a thought stuck in your head and you're doing these weird actions, or you're, spending the entire water in 1 hour's time. So when people don't see that as people recognize that as a symptom, that's when people are not even going to blink, and they'll be like, oh, this is happening, go, let's just go find out if there's a problem, and if there's a problem, we'll fix it. They'll be as pragmatic about it. It's like, even 20 years or down 2 decades ago, if somebody had leprosy or tuberculosis, they were shunned and they were kept away and all of that. And now we know that we don't do that anymore, just because people understand that, okay, I don't need to hide from somebody who has tuberculosis, because they're going to get treatment and they're going to be okay. So the same way, then that level of understanding comes that, okay, if there is a problem, I'm going to get it checked out first, get it diagnosed. Is it a problem, or is it something that, yeah, I mean, it's just flu, it's not tuberculosis, or it's just a headache, but it's not migraine, or oh, it's just like somebody broke your nose and you don't have COVID, and that's why you can't smell. So when people understand that, it'll get easier, definitely. So instead of what I would suggest to people, especially the young people, is that because you guys are so great about checking up on stuff, reading up on stuff, arming yourself with information. But what I'm also going to say is that it's going to help if you are going to also follow through and be more professional towards your approach. If you go and tell your parents that I am feeling these symptoms for this long, and I need to see a doctor to see whether I have a disorder or no, instead of going and saying I have depression, take me to a doctor. Because don't self-diagnose, because when you're self-diagnosing, people are going to be, they're going to just say that, oh, it's such a snowflakey kind of a thing to do. So don't do that. That will in fact help you. Tell them that these are my symptoms. This is how long this has been happening. I read up. I think it could be this, but of course I'm not going to take my word for it or Google's word for it. They didn't go to medical college. So let me go see a doctor and get it diagnosed. So when you have that kind of a conversation with people, and in face of that kind of rationality and systemic kind of approach and professional approach to it, how are people going to say no? They're going to feel silly saying no to you.
Yeah. Okay, ma'am. Yeah. So, Dr. Rukshida, we had a lot to gain to hear from you. That's a great thing. We got a chance to have a session with you on our page on OCD. I always wanted to talk about this disorder because I've heard so much, and even on your page, like on Google, I found that you have been doing a OCD specialization. So I wanted you to speak on it. I wanted only you. So yes, ma'am, thank you so much, and we hope and we can see you ahead also for some or the other sessions on our page. Thank you so much for coming.
Thank you so much for having me. And like I said, you can't pay me enough to shut up talking about mental health. So I'm very happy that I got the opportunity to speak with you. And yeah, more power to you for doing the good work and spreading the good word. And every little counts. And I think when we talk about it in this manner, it dispels so much of misinformation and stigma, isn't it? And even if we manage to reach 1% people who are going to take help for themselves, I think our job here is done then, isn't it? So thank you so much. It was a pleasure talking to you. And yes, I will come back if you want me back.
Thank you so much. Yes, ma'am. Thank you so much.
All right. Thank you so much. Bye.
Bye.